Welcome to another deep dive. Today, we're setting our sights on a subject that most governments, economists, and, well, policymakers consider to be the ultimate labyrinth.
Right.
We're talking about the modern medical system.
The big one.
The big one, exactly. We are going to carefully examine a highly complex theoretical blueprint for essentially dismantling the current healthcare infrastructure and rebuilding it from the ground up.
Which is quite the undertaking.
It really is. And our source material for this exploration is the 16th University Workshop led by Professor Wojan Shonk.
Yeah, and to understand the architecture of this blueprint, it really helps to understand the architect.
Right.
Professor Schunk is not a medical doctor. He approaches these issues with the mindset of a systems engineer.
Which is a completely different vantage point.
Exactly. For the past 5 years, he has dedicated himself to analyzing these large-scale societal structures. I mean, he has applied his engineering principles to education, to taxation, to pension systems.
But healthcare is a different beast.
It is. Yet, as he admits right at the beginning of this particular workshop, healthcare has remained his most difficult challenge. It is the hardest problem he has faced.
A puzzle that resists elegant solutions.
Completely.
Okay, let's unpack this. We need to establish a very specific premise before we go any further into the weeds here. Our entire discussion today is focused on structural incentives.
Right.
We are looking at the architecture of the systems that medical professionals are forced to operate within. This is not, and I want to be very clear for you listening, this is not an evaluation of individual doctors.
Not at all.
It's not about their personal morality or their dedication to the Hippocratic Oath.
We are examining how the rules of a game dictate the behavior of the players.
Precisely. And the professor starts by pointing out a fundamental hurdle, which he calls the measurement problem. Why does healthcare defy the kind of engineering that works so reliably in other fields?
Yeah, and he uses education as a contrast, which I found quite clarifying.
It's a very useful comparison.
It is. Because in education, designing a self-regulating system, what engineers would call a system with a functional negative feedback loop, is, theoretically at least, straightforward.
Because you can measure the output.
Exactly. The ultimate metric for success is quantifiable. You can, over time, track a student's future salary.
Right. You can see if the degree actually paid off in the real world.
Yes. If a university consistently produces graduates who command high salaries in their respective fields, the market has objectively validated the quality of that education. The feedback loop functions properly. You adjust the curriculum based on that clear, measurable outcome.
But when you transition to healthcare,
that clarity just vanishes. How do you objectively measure the success of a medical intervention across a whole population?
now for anyone listening, that seems like a question with a seemingly obvious answer. Surely success is just keeping the patient alive.
If only it were that simple. Defining a successful medical outcome is incredibly ambiguous. Is success strictly defined as prolonging life, even if the quality of that extended life is characterized by severe pain?
Or cognitive decline, yeah.
Or is success minimizing suffering, even if it means a shorter lifespan?
It's subjective.
Highly subjective.
Yeah.
Furthermore, the baseline of the raw material we're dealing with, the human body, is wildly inconsistent.
Right. No two people are the same.
Consider 2 patients undergoing the exact same cardiac surgery. One is a genetically robust 30-year-old athlete.
Okay.
The other is an 80-year-old with a history of diabetes and a 30-year smoking habit.
A completely different starting point.
Exactly. If both survived the operation, was the surgeon equally successful in both cases?
You can't really say they were. The variables are nearly infinite.
What's fascinating here is that because we cannot easily standardize this metric of health, previous historical attempts to engineer healthcare systems have generally fallen into 2 dominant, yet ultimately flawed paradigms.
And the professor breaks these 2 historical paradigms down quite thoroughly in the workshop.
He does.
The first is what he terms the state or welfare model. If we look at the historical roots, this is grounded in the philosophies of Karl Marx regarding collective ownership and equitable distribution.
Right.
And it was first practically implemented on a national scale by Otto von Bismarck in 19th century Germany, which is a bit ironic.
It is, considering Bismarck was a conservative who instituted a welfare state largely to preempt the rise of socialist movements.
A brilliant political maneuver at the time. But in this model, the state guarantees that every citizen has the right to the same nominally free medical services. It relies on a vast mandatory pooling of resources.
You pay in through taxes.
Exactly. The system takes taxes from the young, the healthy, and the economically successful and redistributes those resources to fund the care of the sick, the elderly, and the less fortunate.
And the underlying intention of the welfare model is rooted in a noble concept of social solidarity.
Yeah.
I mean, no one should die simply because they're poor. However, the structural reality of this model often leads to severe, predictable inefficiencies.
Because of the demand?
Precisely. When a service is entirely free at the point of use, the demand for that service will inevitably outstrip the finite supply of doctors, hospital beds, and MRI machines.
Which leads to rationing.
Yes. The result is rationing by time. You see this in the extensive wait times common in state-run systems. A patient might wait 6 months for a crucial joint replacement.
And wait times aren't the only structural flaw here. There is the issue of compensation for the professionals.
A huge issue.
In these state systems, medical professionals are frequently paid relatively low, fixed salaries that do not scale with their performance.
Or the complexity of the cases they take on.
Right. A surgeon who performs 3 complex, life-saving operations a week earns the exact same base salary as a surgeon who performs 10 routine, low-risk procedures.
Which creates a very specific economic pressure. The professor notes a somewhat cynical but historically validated axiom.
Let's hear it.
When you combine a system of low, fixed wages with incredibly high-stakes outcomes, like human health, you create a highly fertile ground for corruption.
Because the stakes are literally life and death.
Exactly. In many centralized state systems, patients who are desperate to bypass those 6-month wait times end up relying on informal networks.
The gray market.
Yeah. They use nepotism, political connections, or direct under-the-table payments to secure timely or high-quality care.
Structurally, this model ends up penalizing the healthy, who pay into the system for years without extracting value, while also failing to deliver efficient care to the truly sick without some form of bribery.
So, to escape the bureaucracy and the wait times, patients who have the financial means naturally look for an alternative.
Right.
It is remarkably common in these hybrid environments for a patient to visit a specialist in a rundown state hospital in the morning, only to be quietly told by that same specialist to come to their pristine private clinic later that afternoon if they want the procedure done this month.
Which brings us to the second paradigm the professor analyzes, the liberal or market model.
Yes, heavily influenced by classical economists like Adam Smith and later Friedrich Hayek.
In this system, healthcare is treated not as a guaranteed right, but as a private commodity. The price mechanism dictates distribution. You pay for the specific services you require.
And the liberal market model certainly addresses the wait times. By utilizing price signals, it allocates resources efficiently to those who can afford them, and it incentivizes rapid technological advancement.
Because there's a profit motive to innovate.
Exactly. However, it introduces an entirely different, arguably more devastating, set of structural flaws. The most obvious is the profound equity issue.
If you can't pay, you don't get care.
Right. If you cannot afford the market rate for a life-saving procedure, and you do not have adequate private insurance, you simply do not receive the treatment. The system leaves the economically disadvantaged behind.
But beyond the moral implications, which are vast, the professor focuses heavily on the deeply problematic incentive structure this creates for the medical professionals themselves.
Right. If a doctor is operating as a private business entity in a free market, their revenue is directly, inextricably tied to the volume of services they provide.
The more they do, the more they earn.
The professor calls this the inverse problem. If you reward a doctor financially, per treatment, per scan, or per consultation, the structural incentive actively encourages them to view healthy or even moderately healthy patients as perpetual revenue streams.
It creates an incentive to overtreat.
It does. The professor shares a rather relatable anecdote from his own life during the workshop. He mentions a time his wife observed that a certain private physician they visited seemed to view him essentially as a kasika prazika, a piggy bank.
A piggy bank.
Yes. If the doctor's income depends on you returning, the structural incentive is to prescribe endless follow-up appointments, suggest minor, arguably unnecessary interventions, and mandate continuous, expensive monitoring.
The market mechanism effectively turns a healthy person into a permanent patient.
Precisely.
And this is where we run straight into the inherent danger of applying engineering concepts like negative feedback loops to biological survival.
Yeah.
A negative feedback loop, like a thermostat in a house, is supposed to be a self-regulating mechanism. If the house gets too cold, the heat kicks on. If it gets too hot, the heat turns off. The system corrects itself based on a metric.
But if your metric for healthcare is flawed, the loop causes immense harm.
Yes, and the professor illustrates this with a highly specific, chilling example from his lecture, which he calls the Dr. Radovanovich paradox.
This paradox perfectly encapsulates the danger of poorly chosen metrics.
Walk us through it.
The professor recounts the story of a famous local physician. We will refer to him as Dr. Radovanovich to keep the focus on the concept.
Okay.
This surgeon achieved a staggering, almost unbelievable 98.5% success rate in his surgical procedures.
Which sounds phenomenal.
Yeah. It sounds perfect. This metric was so exceptionally high that the hospital administration actually dedicated a bus to him. On paper, according to the purely numerical data, he was the greatest surgeon in the region.
The feedback loop is telling the system, this is what excellence looks like.
Exactly.
But the reality beneath that statistic was entirely different. How did he actually achieve a 98.5% survival rate? It wasn't through miraculous surgical skill alone.
No.
The professor points out that if a system, or even just the informal culture of professional prestige, rewards a doctor purely for maintaining a high survival rate, that doctor is structurally incentivized to become incredibly risk-averse.
Precisely. To protect that flawless statistic, this doctor would simply decline to operate on high-risk, difficult, or terminally ill patients.
He curated his patients.
He did. When a complex case arrived, perhaps a patient with multiple comorbidities where the chance of survival is only 40%, he would refuse the surgery.
Even if surgery was their only hope?
Yes, often referring those desperate cases to other hospitals or military medical academies. He achieved his pristine record by primarily operating on patients who were relatively healthy, where the procedure was routine and survival was virtually guaranteed.
It is a dark consequence of optimizing for the wrong number. If the overarching goal of the system is a high success rate, the system will naturally select for easy cases.
And the most desperate patients, the ones who need surgical intervention the most, are left without care because they represent a statistical risk to the surgeon's reputation.
The system functions perfectly according to its designed metric, but it fails completely in its fundamental medical duty to heal the sick.
So we are left with a severe dichotomy.
Right. Neither the state monopoly nor the pure free market functions optimally. The state model creates immense wait lines, suppresses wages, and fosters a culture of under-the-table bribery.
And the market model abandons the poor and structurally incentivizes doctors to either overtreat the healthy to maximize revenue or avoid the truly sick to protect their statistics.
It's a deadlock.
It is. To navigate out of this deadlock, Professor Schenk proposes a radical, systemic restructuring. He moves toward a philosophy he defines as social liberalism.
Social liberalism.
Yes, this involves a complete teardown of the current architecture, replacing it with a three-tiered separation.
The goal of this social liberalism approach is essentially to thread the needle. He wants to retain the universal accessibility and the social safety net of the Bismarck welfare model.
Right.
But he wants to combine it with the efficiency, the competitive pricing, and the rapid technological advancement of the Hayek market model.
And to achieve this, he argues that the current state monopoly on healthcare administration must be entirely dismantled.
In its place, he proposes dividing the physical and professional infrastructure of healthcare into three strictly separate, privately operated entities.
But before we detail those three entities, there is a very specific transitional mechanism the professor proposes that we need to examine.
Okay.
He suggests that while these new entities would be privately operated, the state would maintain a mandatory 30% ownership stake in all of them.
In all of them.
Yes. And this rule applies even to existing privately owned clinics transitioning into the new system. They would undergo a 30% nationalization.
Now, I have to pause you there because that sounds like a recipe for immediate capital flight.
It does.
If a government suddenly announces it is seizing 30% of every private medical business, wouldn't clinic owners simply close up shop, move their assets abroad, or refuse to participate? I mean, it sounds like outright expropriation.
It would be if the state simply seized the assets without compensation. But the blueprint dictates that the state compensates the private owners for that 30% stake.
Okay, so they buy it.
Yes. But the valuation is where the professor introduces a rather cunning mathematical trap.
A trap.
The state does not negotiate the value of the clinic based on its current market potential or the owner's asking price.
Then what do they use?
The state compensates the owners for that 30% stake based strictly on the reported revenue from the clinic's previous tax year.
Ah, I see the friction there. That is a fascinating mechanism for exposing the gray economy.
Isn't it?
Because in many systems, private clinics might maintain two sets of books, severely underreporting their true income to evade corporate taxes.
Exactly. Under this proposed transition, if a clinic had been successfully hiding its true revenue from the tax authorities for years, the state would purchase its mandatory 30% share at that artificially low, fraudulently reported valuation.
So the clinic owners are caught in their own lie.
Yes, they lose a significant portion of their company's actual real-world value precisely because they lied on their ledgers.
It acts as a one-time structural punishment for past tax evasion.
And it enforces immediate financial transparency as the new system launches, without requiring massive retrospective criminal investigations. You just use their own math against them.
It is a harsh yet logically unassailable transition. You are bought out at the exact price you claimed you were worth to the taxman.
Exactly.
So assuming we survive the transition, we enter this newly structured world of healthcare. The system is split into three distinct tiers.
Let's examine Entity 1, hospitals.
Under this blueprint, the concept of a hospital undergoes a massive reduction in scope. They no longer employ doctors. They do not manage patient care or dictate medical policy.
The hospital is reduced to a purely infrastructural real estate entity.
Their role becomes strictly logistical.
Yes. They own the physical buildings, the wards, the intensive care units, and the operating theaters.
They provide the space.
They are also responsible for purchasing and maintaining the heavy, expensive capital equipment, things like 20 million euro MRI scanners or robotic surgery suites.
And they employ the maintenance staff, the hygiene crews, and the security personnel.
And that is where their involvement ends. Their entire business model is simply maintaining a state-of-the-art facility and renting out that space.
Which fundamentally alters the power dynamic. It addresses the current conflict of interest where a hospital director, who is often a chief surgeon themselves, has to balance the clinical needs of patients with the mundane logistics of building maintenance, union negotiations for the cleaning staff, and equipment procurement.
Right, you separate the medicine from the plumbing.
By isolating the infrastructure, you create a dedicated corporate entity whose sole profit motive is to provide the cleanest, most technologically advanced, and most efficient physical space possible.
Because if a hospital fails to maintain impeccable hygiene standards, or if they refuse to upgrade their outdated scanners, no one will want to rent their space.
Which leads us directly to the people doing the renting. Entity 2 is the clinics, or what the professor refers to as ordinances.
Because hospitals have been stripped of their ability to employ medical staff, the doctors, the nurses, the anesthesiologists, and the specialized medical technicians all organize themselves into these independent clinics.
You can visualize these clinics almost like highly specialized mobile strike teams.
I like that analogy.
They do not necessarily need to own a massive multi-story building to operate. Instead, they rent specific time slots and operating rooms from the infrastructural hospitals.
The professor uses a helpful analogy here, comparing it to the aviation industry.
Right.
British Airways or Delta does not own Heathrow or JFK.
They just use them.
The airport authority is a separate entity that owns the runways, the terminals, and the security infrastructure. The airline simply rents the gates and the landing slots to conduct its primary business, which is flying passengers.
In this new medical model, the surgical clinics are the airlines and the hospitals are the airports.
It is an elegant way to enforce competition.
How so?
A specialized orthopedic clinic might rent an operating theater in Hospital A on Mondays and Wednesdays because Hospital A offers a better rate on surgical suites.
Okay.
But they might rent space in Hospital B on Thursdays because Hospital B has invested in a superior post-operative physical therapy wing.
This structure forces hospitals to actively compete with one another to attract the best medical talent by offering superior equipment and competitive rental rates.
Concurrently, it forces the clinics to compete purely on the quality of their medical care and their efficiency.
Entirely unburdened by the overhead of replacing the roof or fixing the HVAC system.
Exactly. It also shatters geographic monopolies.
That's a huge point.
A patient living in a specific district is no longer bound to accept the varying quality of whatever state hospital happens to be in their town, because the doctors themselves are mobile and operating in a competitive marketplace.
But this entire structure, private landlords renting to private strike teams, is still fundamentally dealing with human health.
We still need a way to evaluate the quality of that medical care.
And we need a mechanism to dictate how these clinics actually get paid, which requires us to look at the most radical and undoubtedly the most complex tier of this entire proposal, Entity 3, inspections.
This third tier is the absolute linchpin of the professor system. Because the state no longer directly manages the doctors and the doctors no longer manage the hospitals, there is a vacuum of accountability.
Who watches the watchman?
Exactly. The system requires a mechanism to enforce strict quality control and, crucially, to determine the financial compensation for the clinics.
And these are the inspections.
The inspections tier consists of entirely independent private medical auditing firms.
Okay, so who staffs these firms?
These firms would be staffed by highly experienced medical professionals, perhaps senior surgeons who have aged out of the grueling physical demands of the operating room, alongside specialized pathologists, health economists, and legal experts.
A multidisciplinary review board.
Yes. Their sole dedicated function in this new economy is to rigorously evaluate the outcome of every single medical intervention provided by the clinics.
We need to spend a significant amount of time lingering on the mechanics of this tier.
It's vital.
Because how these inspectors operate is Professor Ann's attempt to solve the impossible measurement problem we discussed at the very beginning of the deep dive.
Let's walk through what we can call the inspector's dilemma.
Okay.
This is the negative feedback loop designed to prevent the new system from collapsing into either a race to the bottom or widespread corruption.
The core question is, how does a doctor actually get paid in this theoretical universe? Under our current market models, the doctor or the hospital sets the price, and you, or your private insurance, pays it. Under the professor's blueprint, the doctor does not set the price.
That represents a massive paradigm shift in healthcare economics.
It's totally inverted.
Let us use a hypothetical scenario to illustrate how this functions. Imagine a patient requires a complex knee replacement. The orthopedic clinic performs the surgery at a rented hospital suite.
Okay.
Once the treatment is complete, and this applies whether the patient makes a full recovery, experiences complications, or tragically passes away, the clinic's comprehensive case file is handed over to one of these independent inspection firms.
So they see everything.
Everything. The inspector's job is to review the entirety of the medical file. They must meticulously compare the before state, the patient's initial diagnosis, their age, their pre-existing conditions, their genetic baseline, with the after state, which is the objective result of the clinic's surgical intervention.
And based on what the professor describes as a massive, highly detailed, standardized medical rulebook, the inspector assigns the clinic's performance a specific grade ranging from 1 to 5.
A grade of 5 means the procedure was flawlessly executed, resulting in the best possible outcome given the patient's specific baseline.
Right. And a grade of 1 means the outcome was disastrous, clearly indicating medical negligence, incompetence, or a severe breach of protocol.
Now, the critical mechanism is this. The orthopedic clinic is paid out of the state health insurance fund, strictly based on that assigned grade.
If they earn a 5, they receive the maximum allocated payment for a knee replacement.
But if they are assigned a 2, they receive a mere fraction of that cost.
The inspector essentially dictates the clinic's revenue after the fact.
Now, any student of human behavior law or economics will immediately spot the massive vulnerabilities in this design.
It's ripe for abuse.
We have introduced an immense adversarial tension into the system. 2 highly dangerous scenarios immediately present themselves.
Scenario 1. What if the inspection firm, perhaps unofficially colluding with the state insurance fund to suppress overall healthcare costs, begins consistently giving falsely low grades?
The state saves millions.
But the surgeons are unfairly undercompensated for excellent life-saving work. That seems like a fast track to doctors going on strike.
It would be. But scenario 2 is arguably far more insidious and far more likely in a real-world economy.
Bribery.
Exactly. What if the inspector simply takes a bribe from the clinic?
Let's play that out. Say our orthopedic surgeon realizes they botched the knee replacement and are looking at a grade of 1, which means they won't even cover the cost of renting the operating theater from the hospital.
They're taking a loss on the surgery.
Right. So the surgeon hands the inspector an envelope of cash under the table. In return, the inspector signs off on a perfect grade of 5, maximizing the clinic's payout from the state fund.
The patient suffers, the state is defrauded, and the corrupt parties profit. How does the system survive that?
This is exactly where the negative feedback loop must have absolute draconian teeth.
Draconian is the word for it. To prevent these scenarios, the professor introduces the super inspector safeguard, and it revolves around a truly punitive financial mechanism, the 10x fine.
The 10x fine.
Let us return to our hypothetical knee surgery. Let's say the inspector reviews the file and assigns a grade of 2, resulting in a very low payout.
The surgeon is furious.
They believe they navigated a highly complex complication brilliantly and genuinely deserve a 5. The clinic has the right to appeal this grade to a higher authority, a super inspection board composed of a randomized mix of private auditors and permanent state medical officials.
This super inspector reviews the appealed case, but they are no longer just evaluating the surgeon's work, they are putting the first inspector's judgment on trial.
Yes.
If the super inspector determines that the first inspector lied, was demonstrably incompetent, or deliberately gave a falsely low grade to save the state money, the consequences for that first inspection firm are catastrophic.
The firm is hit with a massive, uninsurable penalty. They must pay 10 times the cost of the highest graded procedure directly out of their own corporate pockets.
Let us run the math on that to understand the severity. If the maximum state payout for a perfect grade 5 knee replacement is, say, 15,000 euros, the inspection firm is fined 150,000 euros for a single misgraded file.
If this happens on a more complex 100,000 euro neurosurgery, the fine is 1 million euros.
That represents absolute financial ruin for an inspection firm.
And to incentivize the clinics to actively root out bad inspectors, 20% of that massive fine is awarded directly to the wrong clinic as compensation for their lost revenue and the damage to their professional reputation.
But the mechanism is symmetrical. The sword swings both ways.
It has to.
What if the orthopedic clinic appealed the grade of 2, but the super inspector reviews the file and finds that the original grade was actually completely accurate?
The surgeon really did perform poorly, and they were just clogging up the system trying to game the appeal process for more money.
In that case, the clinic pays the 10x fine, and a percentage of their penalty goes to the vindicated inspection firm for wasting their time.
If we connect this to the bigger picture, this mechanical tension is the very heart of the professor's entire proposal. It is a system designed to mathematically force objective grading through mutual terror.
Mutual terror, that's a great way to put it.
Let us revisit the bribery scenario with his new rule in place. Our surgeon offers the inspector a 5,000 euro bribe to upgrade a botched surgery from a 1 to a 5.
The inspector must now calculate the risk.
If they accept the bribe, they make a small illicit profit. But they know that any case, at any time, can be randomly selected for audit by the state super inspectors.
The risk of getting caught is ever present.
If they are caught, the inspector doesn't just lose their job. Their firm pays a crippling 10x penalty that will likely bankrupt them, and the individual inspector faces immediate criminal fraud charges and the permanent loss of their medical license.
The financial and legal risk of lying vastly, overwhelmingly outweighs the minor short-term benefit of a bribe.
The inspector is caught between Scylla and Charybdis. They are forced to walk the incredibly narrow path of pure, objective truth.
Because deviating in either direction, falsely low or falsely high, leads directly to financial destruction.
It is a high-stakes, highly adversarial ecosystem. The clinic wants a high grade to survive. The inspector wants to give an impeccably accurate grade to avoid being bankrupted by the super inspector.
The hospital just wants the rent paid on time.
Right. Everyone is watching everyone else, driven entirely by their own financial self-interest, which, theoretically, results in the highest possible quality of care for the patient.
It is a fascinating application of game theory to medicine.
But this intricate dance of clinics, landlords, and terrified inspectors raises a very practical macroeconomic question.
Which is?
We have detailed how the state insurance fund pays the clinics based on these grades, but where does the state fund actually get its capital?
How do citizens, the people actually using this system, interact with it financially?
Exactly. This requires us to examine the fourth pillar of the deep dive, the redefinition of health insurance.
The professor's model seeks to entirely eliminate the traditional, opaque health contributions that characterize most modern state systems.
Currently, in many countries, a percentage is automatically deducted from a worker's paycheck.
The citizen often has no idea what the actual monetary value of their contribution is, nor do they truly understand what specific treatments that payment entitles them to. It functions as a black box.
The professor replaces this black box with a highly transparent, multi-tiered approach designed to force the citizen to make conscious, deliberate economic choices about their own health coverage.
He divides coverage into three distinct tiers. Tier 1 is categorized as basic survival.
This is the foundation of the healthcare system.
And crucially, it is the only mandatory component. A fixed, transparent percentage is deducted from every citizen's personal tax account.
This tier is strictly reserved for absolute life-threatening emergencies, highly contagious diseases, and severe accidental trauma.
We are talking about critical oncology treatments, emergency interventions for heart attacks and strokes.
Mobilizing resources for a pandemic virus, like COVID-19, or complex trauma surgery if you are in a catastrophic car accident.
These are considered acts of higher power or unpredictable, unavoidable tragedies, and society collectively guarantees your survival and stabilization.
It is essential to notice what is explicitly excluded from Tier 1.
Right. Routine care that does not threaten your immediate biological survival is not covered by that mandatory tax deduction.
If a citizen wants coverage beyond simply not dying, they must actively enter Tier 2, quality of life.
This tier covers services that improve your daily existence but aren't matters of life and death. This includes dentistry, optometry, routine physical therapy.
Or balneotherapy, which is specialized spa rehabilitation.
If you want the state insurance fund to pay for your new prescription glasses or to cover the cost of a root canal, you must make a conscious decision to pay an additional voluntary monthly premium out of your private disposable income.
You are essentially purchasing an add-on package to your basic state survival insurance. You are forced to weigh the cost of the premium against the likelihood of needing the service.
And the system expands further into Tier 3, elective treatments.
This covers procedures that are entirely optional, aesthetic, or lifestyle-driven.
We are talking about plastic surgery, cosmetic lip fillers, elective hair transplants, or other non-survival interventions.
If a citizen wants these procedures covered by the collective fund, they must opt into a significantly higher monthly premium.
The professor notes that while some purists might find it frivolous or inappropriate for a state system to insure something like hair transplants,
in a truly liberal market, if a citizen is willing to pay the actuarial cost of that specific risk pool, the system should structurally allow it.
however, any actuary will tell you that a system relying on voluntary premiums for highly specific, expensive coverages is incredibly vulnerable to a phenomenon known as adverse selection.
As well as outright fraud.
Let us imagine a scenario where a citizen decides they want a high-end 20,000 euro hair transplant.
In a poorly designed, purely voluntary system, they might simply opt into the Tier 3 premium, pay the high monthly fee for a single month, schedule and undergo the expensive surgery, and then immediately cancel their premium the following month once the procedure is complete.
They would have contributed perhaps 200 euros to extract 20,000 euros of value.
Effectively bankrupting the collective fund.
To prevent this kind of smash and grab on the public coffers, the professor introduces a rather severe, mathematically rigid anti-fraud mechanism, the 5-year retroactive rule.
If you suddenly decide you want Tier 3 coverage for that hair transplant, you cannot simply start paying your premium today and get the surgery next week.
To gain access to the capital in that specific tier, you must pay the required premium retroactively for the past 5 full years.
And if you are a younger citizen who has been in the workforce for less than 5 years, you must pay the premium retroactively back to the exact date you entered the taxable workforce.
This mathematical barrier ensures the long-term solvency of the fund.
It forces individuals to plan their coverage comprehensively over a multi-year horizon, rather than treating the state insurance fund like a short-term, zero-interest credit card.
It guarantees that the pool of capital is genuinely sufficient to cover the immense costs of the elective procedures being demanded by the participants.
So what does this all mean?
It's a structure that demands financial foresight. It removes the comfortable illusion that healthcare is an invisible, infinite resource quietly guaranteed by the state.
Under this system, you are acutely, painfully aware of exactly what your basic survival costs you in mandatory taxes.
And you must make deliberate, budget-impacting decisions at the kitchen table if you want the luxury of state-funded dental care or cosmetic surgery. You are an active participant in the economics of your own biology.
And this overarching philosophy, the idea of making the true long-term cost of health visible and immediate, extends deeply into the professor's approach to public health hazards.
This is perhaps one of the most structurally aggressive and politically difficult parts of his entire proposal.
It brings us to the concept of the syntax, or what he terms the healthcare excise.
The professor argues that if a citizen freely engages in voluntary behaviors or consumes products that statistically guarantee massive future medical expenses, the collective society should not be forced to bear the financial burden of those individual choices.
We are primarily talking about items that are known drivers of public health crises: tobacco, alcohol, heavily processed sugars, certain chemical additives.
Currently, many countries heavily tax these items. But in most systems, the revenue generated from a tax on cigarettes simply disappears into the general government treasury.
It is often spent on completely unrelated projects.
Building a new highway, funding the military, or paying down national debt.
The professor introduces a strict, unyielding prepayment concept. Under his proposed system, 100% of the excise taxes levied on these specific health hazard items are funneled directly and exclusively into the healthcare fund.
The economic logic here is profoundly direct. When a citizen purchases a pack of cigarettes, the heavy tax they pay at the register is no longer conceptualized as a mere behavioral penalty or a general revenue generator for the state.
Mathematically, that smoker is actively prepaying the state insurance fund for their own statistically probable future lung cancer treatment.
They're directly funding the intensive care resources, the oncology wards, and the specialized clinics that their lifestyle choices will eventually consume.
If they smoke their entire adult life and develop chronic respiratory failure at age 60, the system is already fully capitalized to treat them.
Because their treatment was funded by their own lifetime of dedicated excise payments.
And the professor broadens the scope of what constitutes a sin or a health hazard significantly. He doesn't just limit this to personal vices like drinking and smoking.
He applies this exact same economic logic to industrial and environmental hazards.
He advocates for massive, dedicated excise taxes on single-use plastics, recognizing the long-term endocrine disruption and environmental damage they cause to the population.
He wants heavy, specific taxes on vehicle emissions, particularly diesel exhaust, with that money flowing directly into the healthcare fund to treat the asthma, cardiovascular diseases, and developmental issues those emissions provably cause in urban centers.
To illustrate how this tax mechanism forces behavioral change on a corporate level, without the need for endless regulations, the professor shares a highly specific anecdote regarding the janitorial staff at his own university faculty.
What happened there?
He discovered that the cleaning staff were being supplied with harsh, industrial-grade hydrochloric acid to clean the faculty toilets.
Why use something so toxic?
The answer was simple economics. The highly toxic acid was significantly cheaper for the university's procurement department to buy in bulk than safer, non-toxic cleaning alternatives.
But the human costs.
As a direct result, the cleaning staff were experiencing chronic lung and respiratory problems from daily inhalation of the fumes.
Let's look at how that plays out in our current system. The university procurement department saves a few $100s a month on their cleaning budget, looking highly efficient on paper.
Meanwhile, the state health system quietly, invisibly absorbs the massive, long-term, multi-thousand-dollar cost of treating the janitor's ruined lungs over the next decade.
The true cost of the acid is hidden from the university's ledger.
Under the professor's proposed system, a severe healthcare excise tax would be aggressively applied to the hydrochloric acid, specifically because it is a known, documented occupational health hazard.
That tax would instantly, artificially make the dangerous acid far more expensive to purchase than the safe, non-toxic alternative.
The university's procurement department, driven purely by their own desire to minimize their budget, would immediately switch to the safe cleaner.
The tax mechanism utilizes the free market's own pricing signals to penalize harmful products, forcing a change in corporate behavior without the state needing to rely on moral appeals, complex occupational safety inspections, or drawn-out class action lawsuits.
It internalizes the externalized costs of doing business.
Now, we must address what is undoubtedly the most radical and controversial application of this philosophy. The professor applies this exact same economic logic to illicit substances.
He takes a stance that is highly provocative, yet entirely internally consistent with his overarching economic model.
He advocates for the complete legalization of all drugs, with the possible hesitant exception of heroin, though he notes even that is open to economic debate.
It is crucial to understand that his argument for legalization is not based on a moral endorsement of drug use, nor is it based on libertarian ideals of personal freedom.
It is based on pure, cold economics and public health risk management.
When drugs are illegal, a vast, violent black market inevitably forms to meet the demand. The massive profits from that market flow entirely to organized crime syndicates and cartels who obviously pay no taxes.
Meanwhile, the state is forced to absorb the immense compounding costs of law enforcement, cartel violence, mass incarceration, and the medical treatment of overdoses resulting from unregulated, contaminated substances.
By legalizing these substances, the state fundamentally destroys the black market's monopoly on supply.
Once the state controls the supply, they would apply a monumental healthcare excise tax to these newly legalized substances. The professor suggests an astronomical multiplier, perhaps 15,000 times the base agricultural or chemical production costs.
The consumer still pays a very high street price for the substance, but instead of that money funding a criminal cartel, that massive premium flows directly, 100%, into the state healthcare fund.
The purchase effectively prepays for the treatment of addiction, the psychiatric care, and the vast social safety nets required to manage substance abuse.
Furthermore, by bringing the consumption out of the shadows of the criminal underworld, the state can actively track usage.
They can mandate monthly medical checkups for registered users as a condition of purchase, and they can offer timely, well-funded addiction treatment at the point of sale.
It shifts the entire issue of drug use from the expensive, punitive realm of the criminal justice system directly into the well-capitalized realm of the public health system.
It is an incredibly pragmatic approach, entirely devoid of moralizing, focused solely on managing risk and allocating capital efficiently.
But as we move into the final phase of our discussion, we have to look at how this highly theoretical, perfectly balanced ledger of risks, taxes, and 10x penalties survives contact with actual human beings.
Because at the end of the professor's workshop, during the Q&A session, the attendees did not just quietly take notes and accept this blueprint, they actively, vocally challenged the core architecture.
And rightfully so. A theoretical engineering model, no matter how elegant on a whiteboard, is only as good as its execution in the messy reality of human society.
A listener in the audience offered a very strong, sustained pushback, specifically targeting the inspections tier.
If you recall, the independent inspectors grading the surgeons from 1 to 5 is the very linchpin of the professor's entire system.
This participant argued that the inspection model, while mathematically sound, is fundamentally impossible to execute in the real world, particularly in the context of a smaller country or a tight-knit region.
Let's really examine the listener's argument because it is deeply grounded in the sociology of medicine.
In a small country, or even a medium-sized state, the medical community is not a vast, anonymous ocean of strangers. It is a highly interconnected, tightly knit village.
The pool of highly specialized experts, say pediatric cardiothoracic surgeons or complex neurosurgeons, is incredibly tiny.
They all attended the same few medical schools. They did their residencies together. They attend the same annual conferences. They know each other's spouses and children.
The listener argues that human nature, empathy, and professional camaraderie will inevitably, consistently override the system's cold, mechanical incentives.
The core of the objection is that doctors will simply protect each other.
We are familiar with the concept of the blue wall of silence in law enforcement. The listener suggests a similar white wall of silence exists in medicine.
Even if an inspector is financially incentivized to give an accurate low grade for a clearly botched surgery, they will hesitate or outright refuse to ruin the career and finances of a colleague they have known intimately for 20 years.
Alternatively, the listener posits that the inspectors, rather than remaining objective arbiters, will simply become corrupt gatekeepers.
They will form quiet, unspoken cartels with the clinics, agreeing to maximize payouts from the state fund in exchange for future favors,
rendering the entire 1 to 5 grading system a useless, highly expensive, performative bureaucracy.
Furthermore, the listener raised a deeply philosophical objection regarding the grading itself. How can you possibly standardize a grade from 1 to 5 when every single human body and every single manifestation of disease is entirely unique?
You cannot compare 2 human patients the way a factory inspector compares 2 silicon microchips off an assembly line.
A grade of 3 for one patient might represent an absolute medical miracle, given their degraded baseline, while a grade of 3 for another patient with a robust baseline might represent sheer negligence.
The infinite variables of genetics, lifestyle, and minute physiological differences make the concept of an objective, standardized grade a dangerous fantasy.
The professor's defense against this onslaught rests entirely on the severity of his engineered negative feedback loop.
He acknowledges the reality of medical camaraderie and he understands the village dynamic. But he argues that camaraderie, like any human bond, has a breaking point. And that breaking point is absolute financial ruin.
He believes that the looming threat of the 10x financial penalty, combined with the imminent threat of criminal fraud charges and the permanent loss of a medical license, is a force strong enough to shatter any professional loyalty.
When faced with the ultimate choice between covering for an old friend's surgical mistake and losing everything they own, their firm and their freedom, the professor wagers that raw economic self-preservation will force the inspector to be ruthlessly objective.
It is a bleak view of human loyalty, assuming that the fear of bankruptcy will always trump friendship. But the audience kept pressing the issue, suggesting the system was simply too rigid to function.
And this is a moment in the workshop that is quite telling. The professor doesn't just dig his heels in and shout down the criticism. He shows remarkable humility for someone who has spent 5 years painstakingly designing a system.
Here's where it gets really interesting.
He genuinely listens to the feedback. During the debate, another audience member suggests a structural compromise to solve the small-town camaraderie problem.
They ask, what if the inspectors aren't a separate, permanent class of retired doctors who know everyone in town? What if currently practicing doctors act as inspectors part-time?
The brilliance of this audience suggestion lies in the mechanism of anonymization.
Under this adjusted model, a doctor practicing in one city could dedicate a small percentage of their weekly working hours to reviewing case files from a completely different city or region.
Crucially, before the file reaches them, it would be rigorously scrubbed of all identifying information. The inspector wouldn't know the patient's name, they wouldn't know the name of the clinic, and they wouldn't know the identity of the surgeon who performed the work.
They are simply evaluating the raw, objective medical data. The preoperative scans, the blood work, the surgical notes, and the postoperative results.
By removing the identities, you remove the camaraderie. You can't protect your friend if you don't know it's your friend's work you are grading.
The professor actually embraces this idea during the workshop. He admits that his original rigid concept of entirely separate inspection firms might be too complicated and overly prone to the exact social bottlenecks the audience identified.
He openly acknowledges to the room that this healthcare blueprint is by far the hardest system he has ever tried to design.
He concedes that the model is likely still a work in progress, requiring significant ongoing refinement and crucial input from actual practicing medical professionals to create the complex grading rubrics.
It is a powerful moment of intellectual honesty, demonstrating the true scientific method. The systems engineer realizes that the human element, the ego, the loyalty, the sheer messy uniqueness of biology, cannot be perfectly contained within a theoretical equation.
The system requires continuous iteration, feedback, and adaptation to reality. And that reflection brings us to the close of this incredibly dense journey.
We have traversed a vast amount of structural theory today.
We started by diagnosing the impossibility of measuring healthcare success and the failures of both the Bismarck welfare state and the Hayek free market.
We explored a radical three-tiered separation, reducing hospitals to mere landlords and elevating clinics to mobile strike teams.
We walked through the high-stakes, adversarial 1-to-5 grading system, backed by the terrifying threat of 10x financial penalties.
And we examined a world where every public health hazard, from diesel exhaust to illicit substances, is heavily taxed to directly fund your basic survival care.
This raises an important question.
If we successfully reduce the infinite messy complexities of the human body and the deeply empathetic, profoundly human act of healing into a mechanical, perfectly balanced ledger of 1 to 5 grades, calculated risks, and draconian financial penalties, do we risk stripping away the fundamental humanity of care?
Are we reducing highly trained, compassionate doctors to mere biological mechanics, perpetually terrified of an auditor's ruinous fine?
Or, conversely, in a world characterized by strictly limited resources and inevitable human fallibility, is cold, mechanical objectivity the only way to actually guarantee that humanity and equitable survival is preserved for everyone?
It is something to chew on long after you finish listening. Is the optimal societal system one that inherently trusts in human goodness and dedication, or is it one that designs a cage of incentives so perfect and so terrifying that human flaws simply cannot escape it? We want to thank you for taking the time to join us on this deep dive. It has been a demanding, intricate, but hopefully rewarding exploration of a problem that affects us all. Until next time.